Hello, ladies and gentlemen. I am Nguyễn Quang Hưng, and I am from Neurospine unit in S.I.S Hospital. And today I will present my topic about microsurgical management of intracranial aneurysm. I would like to thank you all of my patients, my brother and teacher for inspiring me to be my best and always help me in case of I need it. And I always thank to Dr. Cường for inviting me. We will talk a little bit about history of surgery to manage intracranial aneurysm. The first case was performed by Norman Dot in 1933, but the two first cases were performed by Walter Dandy. He using a vascular clip was invented by Harvey Cushing, and later Zasakzin and his colleague used microscopic to develop an assay for the more complex aneurysm surgery. As you know, aneurysm of the brain have the prevalence of 1.2 to 7.9. Follow the study of Van Gien. And most of the intracranial aneurysm has the high rupture rate, about 80% in most cases, and about 2% happen during childhood, with highly overall mortality at 6 months, as you see, and about most 1/4 of the patient may die before coming to the hospital, and about 25% may get severe within 24 first hours. Only 1/3 of those who survive have functional independent life, and the rebleeding rate has catastrophic morbidity, and so we recommend strongly treatment for high risk or a rupture aneurysm. When we see an aneurysm, we will ask about the natural history, what we don't treat or when we treat. About risk of subarachnoid hemorrhage is about 1.05 to 6% each year, and if we don't do anything, about half of these will be rupture and maybe cause fatal. If we follow any intracranial aneurysm, if the size of the aneurysm increase in 1 centimeter, it will increase the risk of rupture to 11-fold. We will see some etiology of intracranial aneurysm. You see the congenital atherosclerotic with hypertension, infection, etc. But in S.I.S Hospital, we perform mostly the atherosclerotic intracranial aneurysm. About a rupture aneurysm, when we follow the patient, if we see the increased size on the serial imaging or the left side or posterior circulation aneurysm, especially the tip of the basilar artery, or the patient may have the history of previous subarachnoid hemorrhage, or patient may have severe headache. The patient have a high risk like cigarette smoking or alcohol consumption. Most of the patients come with us with warning headache. It may reveal the minor blood or the high risk of rupture, or the aneurysm may expand the size. If you don't treat this aneurysm, the patient may get worsening, as Dr. Cường said in his lecture. When we see the patient in the clinic, some patients come with us with nuchal headache, rigid headache. Some doctor may consider the patient may have cervical spine disorder, but with our 3 Tesla MRI, we can access through the head and the spinal cord, and so we can incidentally discover the unruptured aneurysm. We treat mostly the ruptured aneurysm, and the patient come with us with 2 main group symptoms. The first group was the rupture group caused by typically subarachnoid hemorrhage, or intracerebral hemorrhage, or intraventricular, even subdural hematoma. The secondary group is symptoms caused by the mass effect, such as the third nerve in P.Con aneurysm, or some aneurysm in cellular and supracellular can cause compress on the chiasmatic, compress on the brainstem to cause cranial neuropathy. But mostly the patient come with the rupture symptom. As you can see, the patient come with us in the comatose. You see, this is the typical imaging of the diffuse subarachnoid in the basilar system, and with massive hemorrhage in brain, and you see the intraventricular hemorrhage. The other come with us, but this patient is alert with his severe headache, and the past medical history is not special, especially about he has traffic accident on his head, and when he come with us, at the first he is fully alert, but then he sudden decrease in Glasgow Coma score, and the emergency CTs reveal an acute subdural hematoma, and we have to transfer him to the DSA room, and the imaging reveals he has a blood blister-like aneurysm. We will talk about some angiography to detect the aneurysm. In S.I.S Hospital, we is the first hospital in Mekong Delta area had the 3 Tesla machine. With the MRI, we can detect the aneurysm with the size larger than 3 mm with the 86% sensitivity. But for me, as I am the neurosurgeon, MRI angiography just show me the size and the shape and the location of the aneurysm, but not showing the relationship with the skull base. But you can see in these cases, if the patient comes with us only with the MRI, we can see enough information about the aneurysm. This patient has the left MCI bifurcation aneurysm and the right P.Con. I see in this emergency status, this is enough for me to perform the cases. Do not perform more like CTs and CTA or DSA. So I am willing to perform this aneurysm cases. And we perform the left meninterium craniotomy, and through this left we exposure the aneurysm and perform the clip as you see on the imaging. Because this is the broad neck of the aneurysm, so we use small clip to control the aneurysm and to preserve the parent artery. And you see the pulse of CTA. And intra imaging is showing the clip, and you can see through this ipsilateral approach, I can see the MCA and the contralateral P.Con, and then I will do the both aneurysm through single approach. The next is the CT angiography. CT angiography can detect the aneurysm like the MRI, but the sensitivity is higher, accompanied with the specificity. You can see this is the multiple aneurysm patient with the locked MCA and ICA aneurysm. But if you just using this information, you can get enough about information about the relationship with code base and the aneurysm. But in case of you want to follow the patient, the MRI cannot show us the follow-up imaging results, because the titanium clip cannot show exactly the flow of the vessel. And DSA is still the gold standard for evaluation of complex aneurysm, especially in case blood-like blister aneurysm. Some cases come with us with typically subarachnoid hemorrhage, but also the DSA cannot rule any aneurysm, and we will perform it in 1 week later. It may give a chance to detect about 10 to 20 cases. You can see this is the case I just showed you. You can see the large MCA with broad neck and the ICA with broad neck. After consult with the interventionally experts, he gave me the patient, and I performed the microsurgical approach to obliterate the 3 aneurysms through single approach. And you can see in the first side we will see the 2 large aneurysms, but actually you can see this is the anterior arachnoid aneurysm is small. So this is proof important to detect the small aneurysm, and we will confirm it through the operation. And this is the post-operation imaging. We treat the patient mostly today now by endovascularly, but actually sometimes with the patient in small aneurysm, we just do conservative treatment like observation and perform serial imaging to follow the patient, and we only give the treat when we see the patient is in the high risk group. Now with the development of endovascular methods, we have many options. About microsurgical, we just do clip. As you see, dynamic calling or standing or even do sacrifice, we just do clip. You can see the trial ISAT was finished on 20. You see, the study was performed to compare about neurosurgical clipping results versus endovascular culling with multi-center. The outcome was measured through two outcomes. The primary outcome was death or dependent as 1 year, and the secondary outcome was rebleeding and the risk of the surgery. Most of the results show us the benefit outcome in endovascular group, but as you can see, the risk of rebleeding is low, but was more found in the culling group. So that's why I perform microsurgical clipping. But actually, the trend of the aneurysm treating was, as you see, this is the chart shows the trend after the S.I.S study about the 2004 to 2014. About the this is the culling group and this is the clipping group. You can see this is chart for rupture aneurysm. Even for unrupture, you can see the highly changing shift into endovascularly management. But sometimes you may review about the literature, because some cases with these suggest may have to give for the patient the operation because massive effect and hydrocephalus or some signs of increased intracerebral pressure, or in case of endovascular option is not favorable, like the case I present with a wide neck aneurysm and acute hemorrhage. If you try to perform endovascularly, the patient may get worsening, like this patient. I have the same patient. You can see she has the typically hemorrhage. This is the pre-operative imaging and this is the post-operative. The patient undergone 6 days in the post-ICU. You see, this is the massive hemorrhage. This is the diffuse hemorrhage. After perform craniotomy, we manage the patient by clip and do the ventriculostomy, and then after that we will inject the RTPA to perform thrombolytic. So you can see the blood in the basal system will dilute. Actually, the patient has 3 aneurysms. The rupture was the MCA, and the 2 is P.Con is unruptured, and the A2 is unruptured. But I will see the patient after she fully recover to do the rest. About the timing how to perform the surgery, as you see, early surgery or as soon as possible. But now the posterior circulation is mostly for endovascularity. Sometimes we have to perform a posterior aneurysm because the patient may have not enough the condition to perform the culling. Same as the anterior circulation, or if the case is more complex, we must have to transfer if we do not have enough ability. you will see the advantages of early surgery. We can virtually eliminate the bleeding rate, facilitate treatment of vasospasm by removal of the vasospasmogenic material. You will see this is the rupture case. The first imaging was performed is MRI, and with this MRI and MI, I performed the surgery, and this is the major acute hemorrhage, and we suck the blood in the cement fissure. You can see it on the postoperative imaging, and after that, the patient was checked with the postoperative CDAs. Sometimes early surgery may have some disadvantages, such as the brain in the acute phase may have swelling, inflammation, and acute clot may make the anatomy is not clear. So if some unexperienced surgeon may have the risk of a highly rupture, and sometimes we can injury or damage the normal anatomy and can cause the severely edema. Some criteria to show us that the patient cannot do early surgery as poor medical condition or severe neurosurgical symptoms or difficult aneurysm or actually active vasospasm. Thanks to the anesthesia team, we mostly perform the rupture aneurysm, and they willing to keep the blood pressure intraoperative about 19 or 20, and when we need to relax the brain, then they may help us in give the osmotic diuretic to help the brain more relaxation. And with our experience, we firstly do symbiont dissection and carefully look the normal anatomy to gain the proximal control. And with the criteria, we try to reduce the intraoperative rupture rate. And if you have to know enough knowledge and experience about neurovascular structure, and sometimes you have to do the brain retraction. But when truly necessary to retract, we use the suction to retract the brain. We call dynamic retraction to minimize the injuries to the brain. Sometimes when we see the patient in the emergency room, we can do anything because the patient is worsening in the eye of us. So to keep the blood pressure always from the beginning to the operating room is so most important. Some tips to manage when we do the aneurysm surgery is using temporary clip to gain proximal control, and sometimes if the brain is swelling, we have to consider the lobectomy to facilitate the exposure of the aneurysm. And this is about a technical tip when we do the aneurysm surgery. This is the tip of Mr. Zhang, the father of microsurgery. You see, we have to verification whenever we do to obliterate or not the aneurysm by puncture to the dome after performing clipping. Some advantage in microsurgical clipping, like cranial-based approach for cranial-based aneurysm, like some ophthalmic aneurysm or some paraclinoidal aneurysm, that the patient cannot have a chance to give the coil. And the intraoperative angiography to confirm whenever the aneurysm is obliteration or not. Now is the ICG. As you in the Western, you can know that, but some surgeon in our country, they may have a chance to see that. That means you give the medicine to the blood like normal medicine, but whenever you inject the medicine to the patient, you shut off the light and turn on the camera, and the blood vessel will show us the anatomy through the brain like you inject the contrast media. Especially clipping consideration is trapping. When I see the large and difficult aneurysm or the recurrent aneurysm after first pulling, or unclippable aneurysm like fusiform blood blister like aneurysm, we have to think about the trapping. But the collateral circulation of the contralateral or the other region of the brain has to be tested by balloon occlusion test. If they may have not a chance to do the trapping, we have to do the revascularization bypass procedure. Like you have the previous blood blister like aneurysm in my previous slide. Yes. And you also see about the ventriculostomy in the previous case. It may have to facilitate the relaxation of the brain during the surgery. You can train the CSF to lowering the ICP or to give the intraventricular thrombolysis. This will remove all the potential vascular mosaic to clear the subarachnoid hemorrhage. That you can do intraoperatively or postoperatively. We talk about the surgery or endovascularly or conservative. That is the goal of the treatment of the aneurysm. You have to completely obliteration of the aneurysm if possible, or if in case of you cannot do the fully obliteration of the aneurysm, you just do the lowering of the rebleeding rate. Also give the patient the option with less morbidity and mortality. And finally is to achieve the good quality of life. This is the protocol to booking a case of aneurysm in our or in any neurovascular center. The patient may have with incidentally discovered or with S.I.S presentation. You have to do on the perioperative screening test and grading the patient with hand and hands, or the grading about World Federation of Neurosurgery, and perform all of the necessary neuroimaging study. You will see why I mentioned about the troponin I in perioperative screening test, because some acute hemorrhage. This troponin eyes may increase slowly, but you have to check about the general condition of the patient. And if the patient cannot do the emergency surgery now, the patient must have to transfer to the ICU unit with monitor. We will check the consonants and the parameter 1 hourly. One of my experience about manage the rupture aneurysm in the ICU is to give the patient the best sedation. Because when the patient has headache, he will increase his blood pressure and may increase the risk of rupture. And we might give the patient an analgesic, strong analgesic like fentanyl because of a benefit effect on lowering ICP and does not cause histamine release unlike morphine. And when available, we have to do the early treatment as soon as possible by calling a surgery. And about the antifibrinolytic therapy, we recommend the tranexamic acid as 1 gram bolus followed by 1 gram every 6 hours until we do the surgery or intervention. I will show you my result about aneurysm surgery in S.I.S Hospital. I performed on 72 patients about the rupture and unruptured aneurysm from the 2019 and 2028. And as you can see, this is the effect of sex on the result. Mostly, the patient is on grade 1 of Fisher scale, and about the physical status, about grade 1 and grade 2 in 90.2 to 28%. And I perform mostly in XCA bifurcation and aneurysm, followed by ACOM, PCOM, and paraclinoidal artery, and even do posterior circulation. Post-operative outcome, we see the 2 patients with my hemiparalysis complication and improved to MRS to 3 after 3-month follow-up, and 10 patients was died. And in follow-up imaging study, 2.78% with remnant aneurysm and just follow, and 1.9 with arterial occlusion. We see this complication in severe atherosclerotic patient. Although we carefully check the blood flow in the distal vessel, we see the blood through the vessel, but actually it's not enough. And when you have special microscope enough to do the ICG, you can see exactly whenever the distal vessel may have enough blood flow, or even they can access for us the Doppler of the vessel, and then you will decide to release the clip using the second clip. The overall outcome is about 83. Maybe because the admission of the grading system still is good. So this is about my recommend book for the other surgeon who want to perform the aneurysm surgery. First, always is the roton cranial anatomy, we have to know about the knowledge of normal, the methods of proton when he exposure the aneurysm. And the second, you can see this is the two book, and the next is 7 aneurysm, the most known of the basic technique for manage 7 commonly aneurysm of Professor Lawton. Thank you for your attention.
Thank you very much, Dr. Any questions from the floor?